Well, good afternoon. I am delighted to be with all of you, and I probably wouldn't be here had I not had an experience about 2002, 2003. I had a great opportunity after a fairly lengthy business career, I won't say how long, to bring together 7 programs into a new nonprofit. And 2 of those programs had a huge impact on older adults. One was 3,400 homeless people, and another was 500 older adults who were coming together for education, health services, etc. And we could not find oral health care. We had the Illinois College of Optometry, we had the podiatrists. We were able to get a lot of volunteer care. So when Oral Health America came knocking, and when our board said in 2008, we want to go into the next frontier, it's not that we don't care about kids anymore, but older adults is the next frontier. I was really all ears, and that's how I come to you today. And I thank the people who have not only provided funding, the DTAF, DentaQuest Foundation, Henry Schein Cares Foundation, people who have contributed their knowledge, because it is tough to raise money for kids. It is moving heaven and earth to raise money for older adults. But as many of you know, your businesses depend upon that population, and so we thank you for being here. Laura, where am I here? Okay. Okay. All right. Okay. So our program is called the Wisdom Tooth Project, and this project is a national project, and it's committed to 3 things. First of all, to educate older adults and their care advisors. Secondly, to connect communities and support them with resources for access to care. And then finally, to advocate for oral health of older adults and for policies going forward that may improve this situation. Initially, I said we want to start a movement. Now I really say we want to further a movement, because I know that this movement is already afoot. But it is an important one, and I'd like to just tell you, before I talk about the grant itself, the key strategies that are involved. First of all, and in the center, is a web portal, which is now in test. It's called toothwisdom.org. We will have a soft launch on May 15th and go national on September 11th of this year. And that portal is not only a national resource, but also a state-by-state resource for oral health services that will be informed by communities, and that relates directly to this grant. Secondly, we have a regional symposia planned on the 1st and 2nd of October, and that symposia is not another meeting to talk about what we all know, but to refresh some knowledge and then to create a template for programs which could be taken into the community, could be put on by an area agency on aging, by a university, and we appreciate the support of Colgate and United Concordia in that effort. Demonstration projects. During the past year, we've been involved in 3 demonstration projects, this grant being one of them. The first is at the University of Buffalo. We've been working with Dr. Glick and a team of medical, social workers, et cetera. And I noticed, by the way, that the social work program at Buffalo was at one point in time a grantee of the DTAF, so that was very nice to read. We had 10 clinics on a Saturday, and people were greeted by a hygienist, they were served by a dentist, a pharmacist looked at their meds, they had an opportunity to visit a diabetes educator, and at the end, their last stop was a social worker who asked them things like, what will it take for you to get to your next appointment? How can we help you with what happened here today during your appointment? Another project was with the University of Florida. We owe a lot to Alice and the work that's been done in plain language, and really wanted to look at what is it going to take this material that we're gathering and really deliver it to very low-income adults in rural settings whose literacy may not even be the plain language level, which is 6th grade, but maybe even less than that. So we did a rural mobile project with the University of Florida. Patrice asked me earlier today, is it published yet? We're not quite ready for that, but indeed it will be the next step of how do we get that down to the level. And then publications. This year we will be publishing a 10th anniversary edition of State of Decay, and that is a look at the older adult health in America. And some of you are familiar with that. So where have we been relative to this project, and how does the DTA Foundation funding play into it? In 2009, we took our first step by having a symposium with the New York Academy of Sciences. Ira Lamster from Columbia was our principal investigator, and we looked at a variety of dental and medical and social issues relative to older adults to gather a body of knowledge that would provide kind of the core for moving forward. From that, we developed a white paper, and we began to float that white paper for people to read and to comment on. And we began working with our first summer intern, pre-dental summer intern, to do an environmental scan and to take a look at really what was out there in terms of resources for older adult oral health. Simultaneously, and this is another serendipity, I think, the Dental Trade Alliance, not the foundation, but the Dental Trade Alliance has been funding a public opinion survey every year for the past 3 years. And one of the things we learned from that in a random selection of 3,000 people is 937 people said that they were caring for an older adult, a neighbor, a friend, a mother, a father. These were not people that were institutional care, but they were folks who were simply all of the people we know. It was such a striking finding that we went back to the DentaQuest Foundation and said, you know, instead of doing X, we'd really like to dig deeper here. And we'd like to find out what's going on with these caregivers. So we conducted a 2-day focus group in the state of Florida online with people who fit the specific role that we felt that we may be wanting to reach. And what we learned was that the number 1 concern was nutrition, the number 4 concern was oral health. Nobody connected the dots that maybe those things had something to do with one another, and that got our wheels spinning. So as we looked at how might we move forward, because at Oral Health America we are not dentists, we took our first report and we vetted this with the ADA's Elder Care Committee. So people with names that all of you would recognize. We said, what do you think about this? You know, are we on the right track? Might we move forward? Then we did a roundtable with public health folks at NOHC. We met with area agencies on aging and Geriatrics Association in DC. And finally, we came up with a concept. And in that concept, we said, if this is ever really going to be meaningful, in addition to the national site, we need to be able to go state by state. And who might be interested in a project like that? And that is when we came to the DTA Foundation and decided to pilot a state page with the state of Connecticut. The entire site is made up of national and local pages. We have MOUs with Special Care Dentistry and the American Dental Hygienists Association to provide content, and we have dental interns and fellows to convert that content into plain language. The dollars in particular went to a conference in Connecticut, multidisciplinary, dentists, hygienists, people from ARP, pharmacists, social workers, and asked them, what do you need? I couldn't tell you of all of it, but I have copies of the summary of all of the things they said they would need in a state resource. So with that, we then went to work and hired Blue State Digital, which is a firm who will allow us to really expand this concept of state pages, because it allows you to go very deep, to deliver information on a personalized basis, to deliver advocacy information, and this is the actual screen homepage of toothwisdom.org. There are blogs, there are health resources, and it will eventually be fully functional for patients, for caregivers, for health professionals. When you click on the state, every state, even today, if you go to toothwisdom.org, will have something in it on your state. However, the robust state, thanks to the funding of the Dental Trade Alliance Foundation, is Connecticut. Eventually, every state, we hope, will have resources for caregiving, dental care, financing care, other resources, social services, and transportation. There was a question asked earlier about taking things to scale, and how are we doing? This taking it to scale is the opportunity to engage every state. We have 4 states standing in line. We have meetings with them this month: the state of Washington, Florida, Arizona, and Michigan, who are hoping to be the next Connecticut. And we find that by engaging oral health coalitions and staying true to our mission, which is connecting communities with resources to improve access to care, that we will need a lot of partners. This is an area where we cannot do it alone. We need not one of us, but all of us. So where do we go from here? Well, first of all, when you go to toothwisdom.org, you'll say, gee, there could be a lot more articles. Yes, there could. Not only from providers, but from companies as well, because many of you have researchers in your businesses who may have something to say. So we welcome additional content. To create 3 to 4 state pages, we thought that was ambitious. Now we think maybe it's not ambitious enough. A marketing strategy, we're working with Edelman, the public relations firm, and we will be launching the national site nationally along with the release of State of Decay, so that it's really a very meaty launch of this project. We will continue with the oral medicine clinics, the State of Decay, the symposium, which I talked about earlier, so that while we are creating and while we are launching, we are continuing to learn. We've learned a great deal. Some of the other people we've learned from is John Landers, and I'm thrilled you've just joined DTA. He was on our corporate advisory committee for this page, and I look around, and there are a lot of people to thank. So I invite you to later on ask questions. I'm happy to share a 1-page resource on what is the Wisdom Tooth Project. If you don't want to take something home, give me your business card and I'll email it to you. And also happy to share what states are looking for and to hear from you if you're from a state where you think this could be a great project, so that the vision of the DTAF to really provide seed money to make a larger impact down the road really is able to be realized through this grant and through your ideas. So I thank you.
Good afternoon, and thank you for the opportunity to, first of all, hear about the exciting projects that are being undertaken and to share a little bit about the project that Apple Tree began with seed money from a Dental Trade Alliance Foundation grant. You were introduced to Apple Tree in the opening video, so I'd like to just run quickly through a few things about our work and then get into details of the grant project and our Apple Tree Rochester program. Our mission is to improve the oral health of people with special access needs who face barriers to care. And this has evolved over the 27 years that Apple Tree has been in existence, from specifically nursing home residents to a number of populations that have reached out to us for assistance. We do this by providing dental care through an innovative nonprofit staff model. We work as a collaborative team, collaboratively within Apple Tree's team and with our community partners. We also advocate for improvements to oral health care systems and financing in order to reach more of the people who need us. You saw our mobile dental office. This is our trademark, what Apple Tree is often known for. You saw this in the video. What you may not know is that Ken Austin, the founder of ADEC, the Austin Dental Equipment Company, met Dr. Helgeson, one of Apple Tree's founders, at a meeting and was so jazzed about what he was trying to do. This was many, many years ago, that he put the R&D into those custom bases. So this is ADEC dental equipment, the same equipment that would be installed in an office and is in fact in our fixed clinics. So when our dentists work in the nursing home and in the office, they're using consistent equipment, and the research and development was done by Ken Austin. Apple Tree uses a hub and spoke model to deliver care, and as shown on this map, the stars are a hub clinic and an operations base. The counties surrounding those hubs are shown in colors, and that is the reach of the mobile dental office going out and providing care at actually now 130 community locations across the state of Minnesota. Across all of Apple Tree's programs, interestingly, we serve, it's broken down a little differently in this slide, but over all the programs, we now see about 1/3 children, 1/3 adults, and 1/3 elders and people with special needs. So we really do serve people of all ages and of all abilities. In the 27 years, the demand for affordable and accessible oral health care has grown significantly. The number of programs that we have has grown to the 5, and the services provided within each of those programs has grown significantly. Each of the regional programs was founded in response to a call for help from a community organization, and each one of those programs has a rather unique flavor depending upon who it was that approached us and what the problem was that they were trying to solve. The specific program that I want to talk with you about today is one that was started at the request of 2 physicians, geriatric physicians from the Mayo Clinic. And I'll just take a minute to tell the story. They approached Apple Tree because they were having such difficulty getting care for their older patients. And they told us the story about being at a hospital with a couple of medical residents in tow, and the nurse leaned over and said, "You're supposed to do a dental exam." So in her words, Dr. Crane says, so I don't even know the tooth numbers, but I donned my glove and went to look in the mouth, and this woman, elderly woman, winced in pain. On closer look, the source of the pain was multiple decayed, broken, and infected teeth. So those teeth and the inability to identify what was going on with them had resulted in multiple hospitalizations for fever of unknown origin, many tests, and great expense, not to mention the suffering of this of this woman. So you'd think, happy story, now we know what the problem was and we can move forward. But unfortunately, it took months to find someone in the area who was prepared to take teeth out of someone with medical complexity, not good mobility, and not good finances. So they'd heard about Appletree and approached us. And it was at about this time that we applied for and received a Dental Trade Alliance Foundation grant, initially envisioned as being a 2-year grant with 2 purposes. The first, to launch the Appletree Elder Care Program, and the second, to pilot a direct reimbursement model, benefits tailored towards seniors and frail elders. We've been talking about how we've leveraged grants, and I just want you to see that this is not from 2008, this is from 2008 on, and it's for the Rochester program, and that $25,000 seed money has definitely grown. We've received grants from the Mayo Foundation, from the Winona Community Foundation, Think Credit Union, Patterson Dental, a number of foundations, and many, many individual donations, people that support our purpose. The first thing, this dental longevity plan stemmed from the fact that most adults do not have good dental coverage, and for better or worse, having insurance coverage often influences whether people seek care or don't seek care. The idea stemmed from the ADA Elder Care Committee and a specific recommendation to investigate alternate funding sources, new ways of financing dental care. The idea was that there are dental services that are essential for seniors, and that if those dental benefits existed, dental providers could provide that needed care. The elders would have access to care, and the result would be improvements in not only their oral health, but their overall health. I won't go in this short time to the specific details about incurred medical expenses, but if you go to the ADA's website, or if you Google incurred medical assistance, medical expenses, you will find a step-by-step guide on how to use this. But in a nutshell, this is a way that seniors can pay for uncovered services. They need a hearing aid, eyeglasses, or dental care that is not covered. And this was the point that we were trying to build from, that a funding mechanism existed. However, traditionally it had just been used to cover services that weren't covered by medical assistance. So if there's a state with no adult dental benefit, incurred medical expenses could be used. We wanted to design a sensible oral health promoting dental benefit that could be funded through the same mechanism. So now to talk about the Rochester program. The second piece was to launch an elder care program, and this was in 2008. Started seeing patients late in 2008, and have grown to serving 19 different facilities. Last year, Rochester saw almost 1,500 patients, provided something like 3,700 dental visits, and did 1,500 in-mouth screenings in nursing homes. We have had to and chosen to diversify the patients that we serve in Rochester. So in addition to the nursing homes, combination nursing home assisted living and assisted living, we're also working with several group homes and group home providers, and also doing outreach clinics. And the outreach clinics were founded in response to serious problems with the dental safety net. A large private dental office that had provided medical assistance dental care gave it up in 2010 when the adult dental benefit set was cut in half, the reimbursement rate was cut by 1/3, and they were told that because they were private dentists, they were not considered critical access. They had thousands of patients who suddenly did not have a dental home, so Appletree responded in partnership with the community location of providing outreach clinics. Couple of photos just to show what we do. This is a nursing home resident being transferred from her wheelchair into our dental chair. And we see patients in their dental chairs. We transfer them to our dental chairs, whatever it takes to be able to provide the right level of care. But you can imagine that rather than requiring special transportation out to an office, being able to provide care where they live is a big benefit for the individual. This is in a memory care Alzheimer's residential program, and Dr. Christian is working very closely with the staff as well to be sure that postoperative instructions are followed up on, and daily care recommended. And I do want to pause because I think I failed to say this in the beginning. Many of the patients that we serve are every bit or more dependent upon others for their oral health care as children are. And I would argue that the consequences of elders having untreated dental disease has huge cost and health implications. So the fact that we can go and we can provide care to someone in a setting that is the most comfortable for them rather than transporting them out, I think goes a long way and speaks to our mission. I just had to leave this in. We take it very seriously, getting the care to people and getting people to care. So this is Dr. Christian at this campus of the Alzheimer's unit with her patient and one of the staff members and his walker, getting him from the cottage where he lives to the cottage where the mobile dental office was set up. Another partnership that has occurred as a result of the Dental Trade Alliance seed money is with the group home provider in Winona, and they were traveling 2.5 hours to a state-operated clinic that had a 2-year wait to get into the operating room, and that by the time patients traveled 2.5 hours, often they were so agitated that they could not cooperate for care. So we have now established on-site services like you saw before, and in addition, an OR program in partnership with Winona Health for those who simply cannot cooperate for dental care. In Rochester, the result of diversifying our patient mix has been that although initially we were nearly 100% elders, those outreach clinics that I mentioned, we now have about 10, almost 11% of our patients are children, and then the remaining 90% is split pretty evenly between adults and elders. So the patients we serve in Rochester has changed since that initial funding. The payer mix is still predominantly public programs, and that has, I'm going to go quickly here, but that has very significant implications for our earned revenue. We work hard, and our dental teams are seeing more people every year, but if you look at what the write-off column is, you can see that working harder does not necessarily get us further ahead. And that is probably our biggest challenge, is that we are working hard, we are working smart, we are providing great care, but state budget deficits, funding cuts, all of these things have impacted us and our ability to treat people very greatly. The optional adults thing is just really, really tough, because if you're faced with multi-million or billion-dollar deficits and something's optional, that's what gets cut. Also, what is needed versus what is covered. And one example of that in 2010, when Minnesota cut about half of its adult dental benefits, one of the services that was cut was what was called the house call fee. And at that time, they paid Appletree about $22, different payers, different amounts, but about $22 to offset our cost to bring our mobile dental office and our staff to that nursing home. Now, we've worked with our partners, found grants, found ways to cover that, but in the meantime, if someone is, instead of seeing us, if they're transported to a dental office using special transportation that can take them on their wheelchair, if they're on oxygen, the state pays manyfold that $22, sometimes $200 or more to transport them. So it's not a system savings by cutting that little house call benefit. The solutions that we have found and that we, frankly, continue to work on and continue to seek are innovative partnerships. And each one of those folks that we have worked with has brought something to the table. Perhaps they provide space for Appletree's mobile dental office to be set up. Perhaps they provide advocacy. We've had great advocacy by our group home providers at the Capitol about why this is important and why it matters for their residents. We have diversified the patients that we're serving, and we feel like we provide fabulous care and that it should be available to everyone. And we are continually seeking ways for private and public funding and private and public partnerships in order to achieve care. And I glossed over a little bit, but the Rochester program started in 2008, and in 2009, 10, and 11, each of those 3 years, we saw cuts in dental benefits in Minnesota. And at the same time, under siege by these amazingly shrinking budgets, staff at the Medicaid agencies actually were saying, we can't think about something innovative. We can't think about adding a dental benefit, all that type of thing. Now we're seeing glimmers that the economy is turning around. There's some new staff at the state that seem to be interested again, not just in finding things to cut, but in ways to provide care better and to look at the big picture of what are we spending, whether it's in the dental benefit or otherwise. So we feel like maybe it's about time for Dental Longevity Plan 2.0. So thank you.
Thank you, Dental Trade Alliance Foundation, for the funding, and thank you for the opportunity to be here and share and network. I'm really excited to be here and learn so much already. Our project is somewhat similar to Dr. Jacobi's in that we are trying to improve the oral health of nursing home elders. The oral health in nursing homes is poor, and that's one of the main issues that we wanted to address, and also the systemic, the oral systemic relationships in nursing homes. We felt like if we could improve the oral health, we could also improve the overall health and decrease expenses. So our project changed. Our original project was to try to improve daily oral hygiene, and to do that by training one person to be the facility oral health specialist. So nursing homes are supposed to provide oral health care, daily hygiene for their residents, but it doesn't usually get done. And there's little oversight for that, there's little accountability. And our thought was if we trained one person to do this, and that was their job, to the exclusion of everything else, all their other duties, and we knew who was accountable, and we went in and worked with this person. We did bedside coaching, hands-on training, care-resistant training, that actually might work. And we had to find a person who was not turned off by brushing the teeth, and we found a great person to do that, someone who actually liked providing daily oral hygiene care, and we trained her to become the facility's oral health specialist. And we were very excited because we had previously done a survey and found that the two greatest barriers for good oral health in nursing homes were, one, providing dental services. A lot of dentists don't want to provide dental services to nursing home patients because of reimbursement and the complexity of their medical problems. And the second reason for poor oral health was difficulty in providing daily oral hygiene care. So we were trying to address that barrier. But shortly after we began our project, we found out that providing toothbrushing was not as benign as we thought. Something that seems pretty simple in a frail population that has multiple complications can be a little risky. So what we found was that some of the nursing home residents had dietary restrictions, which prevented them from intake of thin liquids. They weren't allowed to have even water. So if they're not allowed to have water, how are we going to put water in their mouth and provide oral hygiene care? And furthermore, these dietary restrictions changed quite frequently. So Monday, Mr. Smith could be okay for thin liquids, and then next Monday it could change. And how could we be on top of all of that? We also found that some patients who had cognitive impairments would swallow anything that was placed in their mouth, or they would not spit. They would just hold it in their mouth and look at you. And so we were having a lot of problems with the regimen. We did not want to choke anyone. So we backed up a bit, called the experts. We called the American Dental Association, and we called the American Academy of Chest Physicians, and they hadn't come across this problem. So we said, okay, we're going to have to back up here and see what else we can do. So another problem we had is that the residents loved the care so much, they were asking for care on other shifts. So our oral health care specialist worked from 7 to 3, but the residents who were getting their teeth brushed in the morning wanted their teeth brushed at night and on the weekends, and we hadn't trained those folks. And so we would go in the evenings and on the weekends and see the nursing assistants providing the care flat, the patient flat. Well, that's an aspiration risk. And all kinds of, I'm a germ person, infection control problems. And then there's this choking thing with the thin liquids, and we said, you know, we're going to have to train everybody here. Everybody needs at least the basic safety protocols, and then we can train this one person and deal with these dietary restrictions. So that's what we did. With permission from the Dental Trade Alliance, we switched gears a bit, and we decided to create an outstanding curriculum for nursing personnel in nursing homes to address these previously undocumented problems in the literature about the safety issues. And with our funding from Dental Trade Allowance, we were able to create really high-quality tools. We had an instructional designer that helped us create PowerPoints. This is the, let's see if I can find the pointer here. Oh, maybe not. On your left is the, that's the web page. We have a web page with all of our training resources located there. Our PowerPoints are created either to be delivered by someone, so there's no voice, or if you look on the right, we have PowerPoints that actually have voiceover, so they can be done as self-study. And that's good because time is a real issue in the nursing home for the nursing assistants. We also created a YouTube video. We were able to hire a commercial video producer and a professional actress, and we created an 11-minute YouTube video. On the right is the actual YouTube video, a screenshot of that video. It's been viewed almost 500 times now, and this hasn't been up very long, so that's good. On the left is the video that's on our website, so it can be accessed either on our website or on YouTube. And that video really addresses what we feel like every nursing assistant needs to know in the nursing home about safety, how to provide oral care safely. Now, we're going to see if I can show you the animation. Oops. We also created an animation. One of the things we learned in the nursing home is that nurses respond to 2 words. It just creates a really good response from them. Not a good response, but it's meaningful to them when you talk about wound care and when you talk about pneumonia. Those 2 things get their attention. And so we thought, how can we get across to them the importance of taking care of the teeth? People are retaining their teeth longer. Not everybody is edentulous in the nursing home anymore. In fact, we saw about half of our patients had their teeth, at least half, and they have terrible amounts of plaque. You just can't imagine. So we made this video about the mouth being a wound, and that this wound needs care, just like any other wound in the body. So let's see if I can get this to play. So the point was, and we would talk about this, a wound that covered the palm of the hand, that surface area is about the same as the surface area of someone who has generalized periodontitis. And then we would say, you know, you've got all that plaque there. That plaque is actually dripping bad germs into the blood. And when those germs get into the blood, they cause all sorts of problems with management of their diabetes. That plaque can be inhaled and cause aspiration pneumonia. It can cause problems with risk of stroke. And that really seemed to resonate with the patients, with the nursing assistants. Let's go back to, and that animation is on the website. So what's special about the training tools created? Well, one thing is that we feel like we're addressing safety precautions that have not been addressed in the past by other training tools. And what we did is we have this information in our PowerPoint and in the video, but we also, for our nursing home, created a red safety precautions laminated sheet. And so the nursing assistants take this with them bedside, and we also have other colored sheets that have task lists. This is like a little recipe card for how to provide daily oral care. Then we also have created different links to help with the time constraints. Nursing assistants are really busy people. They have a lot of jobs to do. So we created an advanced curriculum for the oral health specialist, which is quite a bit longer. But we also have basic training for all nursing assistants. We have that 11-minute video, and in a real time crunch, they could watch that on their own time. We have a 30-minute PowerPoint and a 45-minute PowerPoint. And all modules were made so that they could either be presented by a dental professional or they could be self-instructional. And much like, I think it was the Wisdom Tooth Project that you presented, we have 3 different groups that we're targeting as well, and that is dental professionals, nursing staff in nursing homes, and then families. So one of the things we have on the family portion is information that families should share with the nursing home when they admit their loved one to the facility. So we have a whole sheet of things that families need to tell the nursing home when they admit their loved one to hopefully help the nursing facility provide better care for them. But the most important thing about these resources is they are free. They're free. There's lots of, there actually are several curriculums out there, but most of them cost money, and these are free. Because they are free, and they're free because of the Dental Trade Alliance Foundation, because they're free, we've had lots of people ask us if they can use them. They don't even have to ask, but they do. We've had state oral health departments. We've had several universities ask and are using these. The Alabama Department of Public Health, Maine CDC, Delta Dental of Iowa, Oral Health Kansas. We're doing a project now with Medical University of South Carolina. Nationally, I noticed that one of the 2012 recipients of a grant through this foundation is the American Medical Directors Association. They are using some of our tools with their oral health toolkit. And we're actually even now in Australia. We have someone who is training nurses in Australia using this curriculum. This project led to legislation. One of our state legislatures got wind of what we were doing and actually passed some legislation that said we would do this, not completely statewide, but there would be some nursing homes in Kentucky that would have oral health specialists trained through money from the state, and they will pay the salary for that person. And then we have leveraged this funding to get another grant from NYU. This is an interprofessional grant, so we'll be using the tools that we use for nursing assistants. We actually have already modified it to train nurses and nurse practitioners at Medical University of South Carolina. Where we're going from here, we need to get the word out about the free resources. I just talked to a New York Times reporter, and she had somehow found the website. Hopefully, I know that every time they interview you, it doesn't actually go to press, but if it does, that would really be exciting and good for oral health. We'll be giving a talk at the Geriatric Society of America annual session in the fall. I think AARP would be a really good place to get the word out. Some geriatric nursing meetings, long-term care meetings. We did publish this project in the Annals of Long-Term Care. And one more thing, and that is the toothbrushes that nursing home residents have to use are awful. They really are. This is what they look like. They're hard, they have huge heads, And these folks already have terrible gums. And you put hard bristles and a big head in somebody's mouth, and they're going to resist care. So I wish we could do better as a nation. I wish we could provide nice, soft, bristled toothbrushes. The person that orders the toothbrushes is the central supply person. They don't know anything about oral health. All they know is they have so much money to spend, and they get the cheapest thing they can get. So that's my little plug for help for our vulnerable elders. Thank you all so much. I really appreciate the opportunity to be here.